So welcome to our first panel. My name is Jamie Reed. I am a previous case manager in a pediatric transgender center. Many of you know me as a whistleblower from the United States. This panel this morning is going to be topic-wise looking at some of the roles of social and cultural contexts around transgender identities in youth. We've heard from a number of experts this morning who have detailed some of the historical perspectives. This panel is going to include some experts who have some experience in the field and can report on some of the most current presentations that are now being seen on the ground. So what I'm going to start with, we have about 30 minutes, is I want to start with a question to everyone on the panel that's going to begin with language and how language has been changing. So the term transsexual used to be the common term that was used, and we've seen that shift to the use of the term transgender. What we're now seeing is identities like non-binary, genderqueer, gender questioning, and I even had a patient use the term in 2022 describing themselves as gender apathetic, yet they were seeking to medically transition. So I would like everyone on the panel to answer this question in the way that a dictionary, or if you imagine that you're writing a tweet and you do not have a blue check mark. So you are stuck to about 2 to 3 sentences. So what does it mean to be trans now versus what it meant in the past? And we can go down the line, or we can go, who wants to start?
No one wants to start on that.
I don't know what it means now. It seems, is it on? It seems that we've adopted such a broad take on what is a transgender, and it's become such a diffuse term that I really don't know what it means. Although I think it is now it's become a non-clinical term. Is I think the main problem for me in a medical setting.
Sorry, you're holding the button.
Does it,
Yeah.
just stay like,
Don't.
But you've reached your.
yeah.
I would say the key thing that has changed in the identification trajectory is that throughout most of history and in the past, people who were true transsexuals desperately wanted to pass as the other gender. They wanted to mind their own business. They didn't want it to be known. And I think now young people want to be trans. They want to belong to this LGBTQIA plus community. They want this sense of prestige, this sense of dignity that's associated with a socially recognized and valorized role. And traditional gender just does not offer that anymore for young people.
I think the word trans and its various iterations, transsexual, transgender, et cetera, I think it's always served as a metaphor to try and explain somebody's experience of gender incongruity. But I think along with a kind of concept creep that we've alluded to so far, this metaphor has really been blown out of proportion. I think the word transgender now offers a metaphor for, I'm not like the other girls, I don't know how to fit in with my peers, my parents think I'm someone, but I'm really someone else. So I see transgender as operating as a kind of metaphor to express some very real and interesting, clinically interesting kinds of distress.
My understanding is that trans used to refer to a set of interventions, socially, legally, medically, to help an individual manage their gender dysphoria and better exist in the world with more comfort within themselves. And the thing that I think has happened is that now you don't even really need gender dysphoria to be trans. It's become this identity that you can opt into and self-identify with or as. And the meaning really is dependent on each individual's perception of what it means for them.
Yeah, I totally agree. I don't have anything to add. Same.
Wow.
We wandered into the enchanted forest and we don't know how to get out. It's gone to the absurd. And taking a cue from you. So I'm regularly involved, as some of the lawyers in the room know, in legal matters, disputes in school districts and other places. And a response to one of my affidavits filed this week said, being by a psychologist, being transgender does not require one to have gender dysphoria.
So we're going to move on to a question that's going to ask of the panel to talk a little bit about these high levels of psychiatric comorbidities that we're seeing. So it does sound like when we listen to some of the historical, evidence that comorbidities have always existed. But what we might be seeing now is high levels of potentially quite severe psychiatric comorbidities. So the question is, how does this relate to the current cohort of trans-identified individuals, and how do these diagnoses show up? Do they show up at the same time, or are we seeing them later? Are we seeing these presentations of the psychiatric comorbidities first? Does sometimes the treatments itself, if we place an individual who has a psychiatric comorbidity in a hospital, does that ever influence a trans identity? So I open this to the panel to kind of discuss these psychiatric comorbidities related to the trans identity.
Are we going for a tweet also?
No,
Okay,
we have about 13 minutes
Okay.
to kind of discuss this.
Since I've started, I'll just say that I feel like youth today are trying to have their basic needs met through self-expression, for group affiliation, for sexual identity, and that the needs for some of them, especially those who struggle with comorbidities, this is one of the main paths in. And I just feel like these are sort of basic human needs that they have. And therefore, I think it's part of why it makes it tough to put it into a pure mental health kind of treatment paradigm.
Thank you. Good question. Speaking as an anthropologist here, I think it's important to point out that social contagion is not just random. So you don't have just any kind of trait that spreads in any kind of context. When we talk about potentially maladaptive traits, like say epidemics of mass fainting or things like that, what we sometimes call mass sociogenic illness or collective stress responses, those tend to occur in particular contexts of a breakdown of traditional points of reference, breakdown in meaning, breakdown in what people take for granted, people's assumptive world. So these are conditions that breed particular kinds of vulnerabilities. I don't need to tell you that we have been facing for many years now, even since before the pandemic, a mental health crisis among youth. We know that there is a very strong association with digital life, with being socialized online. There's all kinds of comorbidities that are already there. Now there's also been a kind of linguistic contagion, as you point out, of an explanatory model. This one-size-fits-all explanation. You suffer, you feel this distress because you're trapped in the wrong body, and because of minority stress, because you're not being kind of recognized. So there's this contagion occurring on all of these levels. So again, we need to understand why real distress is on the rise among youth. There's much lower social and cultural regulation of emotion. There's much lower trust in institutions, lower trust in traditional forms of expertise, authority, forms of care. Young people are lonely, they're scared, they're burdened with the responsibility to reinvent their lives, to reinvent their genders. We're no longer able to provide any kinds of safe limits for them. So again, the conditions are a perfect breeding ground for the kind of epidemic that we're seeing now.
Yeah, I agree so much with what's been said so far. And I also think we exist, especially in the populations that I work with and the families I work with, they exist in a kind of paradigm that really in some ways doesn't trust institutions, but in some ways over-relies on institutions. So we have a high reliance on psychiatric diagnostic measures. When there is a sense of distress, the types of families I tend to work with, I think of them as hyper-resourceful, right? They're going to find the best expert to take their kid to. If their kid is, struggling with academics, they'll find them the best tutor. If their kid is struggling with mental health, they're going to find the best psychiatrist in town. So I think a lot of families are already primed to kind of see the distress in a way that is very rational. We're going to use, the power of science and psychiatry and medicine and whatever other tools to understand what is going on. And something I wanted to lift up that I've unfortunately heard over and over and over in hundreds of parents' consults is that sometimes families have a highly distressed child who's maybe had a suicide attempt or, taken too many Tylenol, something that is distressing, maybe not a legitimate attempt to where the child's life was really at risk, but it was really distressing. So families will bring the child to a psychiatric hospital. And in the process of going through that treatment facility, they're screened for all kinds of different things, sometimes for gender issues. So to your question, Jamie, about whether or not a hospitalization can either exacerbate or sometimes act as a first-time vector for gender dysphoria, I've definitely seen that happen multiple times. And you have the power of an authority figure at a hospital who seems to be this competent adult who's going to guide you through your distress, and you are perhaps told, the reason you're having these feelings is because you might have gender dysphoria. There's something really comforting about having that clarity and guidance, whereas mental health distress can often be vague and really scary without a clear pathway out. So, yeah.
That's really beautifully said, and I would just add to that, what I've seen with adolescent onset gender dysphoric patients is that when they come into the therapy room, they initially lead with gender, but then what they bring in very quickly dissolves into other issues that points to the gender identity being used as a coping mechanism to help them deal with something else and to communicate something to the family system that they're unable to communicate in a more clear, direct way. The more I do this work, the more I see a reiteration of dynamic processes of connecting and separating that begins at birth and reaches its peak at sexual unfolding. And I've begun to really look at trans identity in adolescence for those who have no prior history of gender nonconformity or gender dysphoria as being something that represents a resistance to sexual unfolding. And so if we look at trans identity as a resistance to sexual unfolding and get really curious about how that's operating within the patient, we can see that, or at least I come to the conclusion that patients who have a vulnerability already biologically for depression or anxiety have this vulnerability kicked up within them, and the resistance is manifested as depression or anxiety, or an obsession with identity that offers them a sense of psychological and emotional stability during an overwhelming time of change.
Well, I would like to change the focus a little bit, if I'm allowed to. So, as it was mentioned yesterday, I think by Rita, the predominance of symptom neurosis has for some time now been superseded by diagnosis of the so-called ego-structural disorders, which are characterized by the inability to form a stable ego identity. And this identification of trans offers meaning that should be clear and allow young people to express their personal suffering in a form acceptable, and this is crucial, to their time and their culture. And at the same time, it's promise attention, the social status as a member of a minority group. And that is what has changed also. So we have to reflect the contingency, or let's say the historical conditionality of medical concepts. As Ethan Waters said, psychiatric disorders are not simply, but diagnosis and classification systems are made. I think some of you, or perhaps the majority, know his brilliant book, Crazy Like Us. The German subtitle is How America is Driving the Rest of the World Crazy. The American subtitle is The Globalization of the American Psyche. As a question, isn't the current trans boom comparable with earlier fashion diagnosis? For most of them, we found a special vulnerability in female teenagers. This is nothing normal or exceptional. We have the multiple personality. The most of the audience will remember the theme in the late 90s. Or if you go back in the history, the hysteria in female, which can be explained by a sexual morality that oppresses women, or anorexia and bulimia nervosa, which can be understood as an implicit criticism of consumerism, and so on. There are lots of other examples. So I will stop here, and I gave you the microphone. Thank you.
I love being last.
We're going to make you first the next time.
It was the great things that they said. We've raised in this cohort of teenagers self-attestation to be the ultimate criterion. And it's unfortunate. This is only possible because there is codependency of overly permissive parents and teachers and clinicians who abdicate their responsibility for proper evaluation of coexisting and co-occurring conditions, of which there's a vast literature. And then there is this fantasy, which is perpetuated in some circles, Dr. Littman, in which the solution to one's problems is simply a gender change, as though that were easy.
So we're going to take 2 minutes to do a really quick introduction. So what I want you to do is I want you to introduce yourself, but before we start, I just want kind of a show of hands. Who is currently seeing patients? Is anyone currently seeing clients or patients? Okay, so that's what I thought. So we have experts up here who have on the ground, current knowledge. So because I know you're all seeing patients, why don't we just do, in our quick introduction, your name, in what capacity you're seeing patients. You don't have to name where you work. Just a little bit about, how you're seeing patients, and then we'll get to my last question. So Erica, do you want to start?
Oh, okay. A new role for me. I'm Erica Anderson. I'm a clinical psychologist for now 45 years. I see a lot of gender patients, all ages, particularly in the last 10 years, a lot of in this population we're very concerned about. I used to see them at UCSF in the gender clinic there, and now just in my private practice, I do a lot of parent consulting with parents who find a way to get to me from lots of places, including in North America and elsewhere.
So did I get it right that you wanted to hear some several examples of?
No. We'll get to that. So right now, Who are you, and where do you see patients?
Okay. Who I am? That's the question. So I'm male, first of all. No, my name is Alexander Korte, and I'm a senior consultant in the Department of Child and Adolescent Psychiatry from the Ludwig-Maximilian-Universität in Munich. And before I worked in the Charité Hospital in Berlin, and I've seen patients since it's nearly 20 years from now.
Perfect. Yeah, we're just establishing the depth of credibility right now.
My name is Paul Garcia-Ryan. I'm a licensed clinical social worker in private practice. My initial training as a psychotherapist was at Colin Lord Community Health Center, which is a leading gender-affirming clinic here in New York City, where the WPATH president-elect is based. I initially worked as a gender-affirming clinician for several years and started to see a lot of things in my practice that made me question the work that I was doing. And I took about a 6-month hiatus from taking on any gender-related cases, did a lot of reflection, and educated myself, resourced myself, and then started to practice in a different way. And I now work with a group of psychotherapists at an organization called the Gender Exploratory Therapy Association, where we're working to support psychotherapists who are courageous enough to do this work with adolescents and their families in a more thoughtful manner.
And Sasha, I'm going to try to speed you up a little bit so we can get to
Okay, micro machines really fast. Okay.
Yes.
My name is Sasha Ayad. I'm a licensed therapist, licensed professional counselor, and I work in private practice with adolescents. I've been working with adolescents for about 15 years. And about 2015, I saw an uptick in parent reports online, as well as students in the school where I was a school counselor, and left there, started my practice in 2016, founded GETA along with a couple of other organizations, and I see patients in private practice, mostly online, some in person.
Will we have time to elaborate in the next question, or do we pack everything in 30 seconds?
I mean, we can skip to the next question.
No, that's okay. I'm Samuel Veissière. I'm an anthropologist, formerly a professor of transcultural psychiatry. I'm a clinician working in a very specialized team in Canada that works with people at risk of ideologically motivated radicalization leading to violence. We have a psychotherapy and psychosocial intervention model. So we do not judge. We do not try to change people's minds. We try to help them understand their grievances and help them with inclusion. If I have time, I'll talk about how across the very broad range of ideologies that we see, from white nationalism, masculinism, Islamic fundamentalism, questions of gender identity are absolutely fundamental.
Right. My name is Kristopher Kaliebe. I'm a board-certified child psychiatrist, general psychiatrist, and forensic psychiatrist. I'm a professor at the University of South Florida in Tampa, Florida. I have a resident clinic where I train residents to see child patients of all sorts. I have an adult psychiatry residency clinic where I help residents to see patients of all sorts. I work about 20 hours a week in juvenile corrections, and I do forensic cases in addition to academic projects.
Okay, so that's going to lead us to our last question. So I'm going to start this off just a tiny bit about the center where I worked in. So in my own center, we saw a number of patients who were experiencing TikTok tics. We had patients who had somatization disorders. We had patients who believed they were blind, and we sent them and they had no physical manifestations. They were walking with a cane. We had patients who believed that they needed to be wheelchair bound. And then we had a number of patients who actually medically transitioned, got testosterone, and then went on to later report that they had DID and other somatization disorders. So we see this relationship, we see some of these parallels. How do you propose that we treat patients with a gender identification who also has some of the most difficult to treat psychological conditions. I've heard that somatization disorders are basically the most difficult to treat mental illness. So how do you propose? Is there a step? Do we treat one first and one later? How do you propose treating these when they're so joined together?
Does an Erica get to start?
Yes, and Erica. Erica, you get to start. Yes.
Okay. Well, I do a developmental history with any patient I see, and with the young people, it includes the report of parents, since obviously parents talked before the kids did, and registered memories before the kids did in words that can be accessible. So I feel like the family assessment is very important. And in terms of co-occurring, coexisting issues, which are frequent and serious in many cases, I want to know what the sort of the thread of the development is of each aspect of what's going on with the young person. And that will then, to some extent, dictate priority, because sometimes we want to treat things consecutively, particularly serious self-harm risk and so on, or we want to treat concurrently depending upon the composition of the problems. Thank you.
Well, it's a difficult question, but just generally, what I've found to be important when it comes to treating gender-distressed adolescents is to really validate the distress and the subjective experience that they're having, and to do so in a way that avoids saying, yes, you are a boy, or yes, you are a girl, or no, you aren't a boy, and no, you aren't a girl. And to instead really focus on de-emphasizing gender and getting them in touch with other parts and aspects of themselves that gender may have been a distraction from, or may have foreclosed upon in their sense of self.
I don't think there's a stepwise process, because we're not a bento box, right? All of these aspects of the person's distress impact one another. So I often think in therapy that one of the things we are trying to do first is create some stabilization. And this is really important to work with the family, especially if you're working, of course, with a minor who still lives at home. And what can happen, I mean, first of all, there are so many different ways to look at that constellation of difficult psychiatric comorbidities and gender dysphoria. But one of the things that I think happens is that the young person may be kind of protesting the difficult aspects of life that they find intolerable. So when you have a somatization disorder and there, let's say, school refusal happening all the time, there may be important things to address to figure out why they aren't going to school, for example, or why they're having these mysterious fainting symptoms. Like, there can be a meaning and a function in those behaviors. And I think being able to hold the young person with a sense of compassion, but also to the expectations of continuing on with the developmental pathway that they're finding so challenging, has to happen in conjunction with the identifying feelings and exploration, all the things that are happening in therapy. So I think if we divert our attention from all of the other distress and focus on the reported presentation, you can actually miss what's really going on, and you kind of collude with the young person's coping strategy.
Thank you. It's a great question. I think an interesting parallel can be drawn between medically unexplained symptoms, somatoform disorders, somatizations of all kinds, and sudden onset gender dysphoria. It is, I think, not random that there's a particular patient group that is susceptible to this broad range of issues. How to deal with it is complex. There is likely not one phenotype that is vulnerable to, say, social contagion or somatoform disorders or body identity problems. There may be something going on with impaired impaired interoceptive abilities. So we know the autistic spectrum, can be implicated. So clinically, a good evaluation, a good developmental history, ruling out things like neurodevelopmental condition is always good. But I would say in my humble clinical experience, the family history, understanding the family dynamic is always really important and yields very interesting findings. And we find that a sort of non-judgmental psychodynamic and family systems approach, when we're lucky to have access to the whole family and even the person's context, the schools, the teachers, that tends to work very well. And again, absolutely always validating the person's distress, but that doesn't mean validating their explanatory model. People come seeking help from medical professionals because they feel distress. It's not necessarily, in fact, most of the time, it's probably not our job to say, yes, your explanation that you read on the internet is true. So the last thing that I'll mention is that the other parallel with medically contested symptoms, one thinks of controversial categories like fibromyalgia, irritable bowel syndrome. These are people who suffer immensely and who try to meet other people who also suffer and who together devise explanations. And there's been a whole patient advocacy movement that can be very helpful in some conditions like, say, breast cancer. But for others, it has also led to a decrease of trust in medical expertise. So people paradoxically lose trust in medical institutions and then place infinite demands on them, but demand only that their explanation be validated and that their desires be accommodated. And that just does not help patients.
All right, I got my own. Iatrogenics is real, and I think that this is something when you work clinically, you see that we can do harm. And I can tell you for sure in the juvenile corrections, because we have a control, we see what happens. If we reward, even inadvertently, of course, reward non-epileptic seizures, self-harm, we get more of it and it gets shaped up. But in those controlled settings, we actually are very successful working with behavior analysts, getting kids to not self-harm, and we turn the attention to other things. We don't accidentally reward kids with extra behavior, extra time, a one-on-one, give you what you want, and it works. And so we really are trying to get the kids to focus away from the thing that they're presenting with and move on to something healthy, something appropriate to focus on, to move on to something correct and not medicalize. And I think this is very pertinent to this question. I'll further reflect upon that that's sort of the opposite of how a lot of our medical system has been built. And unfortunately, we just don't admit that we do harm most of the time. And I think that's part of why we're all here, is because we're concerned about that.
So we actually have 2 minutes. Is there any questions from the audience? That maybe one or two? So Ken, I will come to you.
I think the discussion of co-occurrence of mental health conditions is really important in light of the CAS review's discussion of diagnostic overshadowing. It took me a while to realize what Cass was saying, but in the UK, presumably they're going to start new clinics, new hubs, and the idea is to have a more holistic approach, right? But here's my question, and I want Sasha to answer this. Which diagnosis overshadows which, and how are these new clinicians going to figure out what is overshadowing what? And once they figure that out, then what do they do?
Okay, so I'm gonna let everyone know we do not have time for another question, unfortunately, but we can let Sasha.
I'm really glad I'm not in charge of setting up all of the services in the UK. I think this is such a good question, and this is what makes, differential diagnosis and thinking about the young person as a whole person so important. I would imagine that there are certain types of really severe psychiatric conditions which would have to be kind of priority number one, like someone who's got schizophrenia, someone who is psychotic. Those are really serious acute mental health conditions that need to be kind of prioritized at the expense of any questions around gender, at least initially. I think there are other types of, more vague conditions, like someone with a generalized anxiety disorder, for example, where, that is kind of at this stage such a broad condition that a lot of people qualify for, especially young people. But I think you have to work on these things at the same time. And I just have hesitancy about prioritizing the gender dysphoria since it seems to encapsulate and engulf so much of the other distress. And as we've kind of touched on, the stories that a young person and a family and a doctor and a therapist tell a person about what their distress means can have a huge impact on how they move forward in thinking about that. So I just have a really big issue with gender dysphoria overshadowing all the other conditions.
And at that, we all